The REDUCE programme is an NIHR-funded project looking at reviewing long-term antidepressant use by careful monitoring in everyday practice. We're currently recruiting practices to take part in Workstream 5 of the REDUCE programme. These are the members of the Southampton team. You can contact us at reduce@sutton.ac.uk. More than 1 in 10 adults are prescribed antidepressants. Some people need to stay on antidepressants long term in order to prevent relapse, but there's evidence that around 30 to 50% of people could stop their antidepressant without relapsing. But it's not always easy to stop antidepressants. Some people restart their medication and others may not try to come off at all as they're afraid of relapsing. Research where GPs are prompted to review patients on long-term antidepressants and advise stopping where appropriate has shown that only around 1 in 14 are able to stop. Because patients can be fearful of stopping and withdrawal can be difficult, patients are likely to need some additional support to help them come off their antidepressants. In our previous work in this programme, we've conducted systematic reviews of patients and practitioner perspectives of tapering antidepressants. We've conducted our own interviews and focus groups with patients and health professionals to understand what difficulties they face and what kind of support would be useful to them. We then used this to develop a digital intervention with telephone support, an online tool and psychological telephone support for patients, and an online tool for practitioners. We then conducted a feasibility trial of this intervention package and are now looking to recruit practices to take part in the fully powered randomised control trial. We're looking to recruit 402 patients, half in each arm, with a view of recruiting 3 to 7 patients per practice. Patients will be assessed using questionnaires at baseline, 3 months, 6 months, 9 months and 12 months. 3-month and 9-month follow-ups will be done online and by post, while the rest are done face-to-face at the GP surgery. We're also looking to complete interviews with 15 to 20 patients and 15 to 20 practitioners in each arm of the study. Our aim is to evaluate the intervention package in supporting patients and practitioners reducing antidepressant medication. Patients will need to have been on antidepressants for more than a year for a first episode or more than 2 years for a recurrent episode. Where patients have had a break from treatment for 2 months or less, we would consider this continuous treatment. Patients should no longer be considered depressed or at a significant risk of relapse. They'll need to be over 18 and be sufficiently fluent in English to be able to participate. We'll be excluding patients who score more than 12 on the PHQ-9 or more than 10 on the GAD-7. If patients express any suicidal ideas, they'll be excluded. That's if they score anything except 0 on question 9 of the PHQ-9. Patients will be excluded if they're currently seeing a psychiatrist, if they have bipolar, psychosis, substance use or dementia, or if they're taking antidepressants for a reason other than depression, for example for neuropathic pain. Practices will be asked to recruit patients opportunistically and through search and mail out. We'd be looking for a minimum of 3 patients and a maximum of 7 patients per practice. Patients will be asked to make an appointment with a GP involved in the study to discuss tapering their antidepressants. We would like this appointment to be within 2 weeks of the patient being consented into the study at baseline. We would like for practices to notify the study team when a patient has had their GP appointment and whether they will be tapering. Some patients may decide with the GP that tapering isn't the right choice for them right now. Even if they decide not to taper, for the study it's still important that we follow up all patients, so we'd still like them to continue with the study if they're happy to do so. We're asking practices to have follow-up appointments with patients who decide to try to taper and to follow up with any patients who have reported suicidal thoughts to the research team. We'd like the GP practices to treat withdrawal and relapse as necessary. We're asking that practices will inform us when a patient has had their GP appointment, that they'll provide a room at the surgery for researchers to conduct questionnaire assessments and interviews, and to allow researchers to have Wi-Fi access to be able to do this. We'd like practices to make sure their reception teams are aware of the study and to involve as many GPs in the study as possible. This will help with patient continuity. We'll be asking practices to complete a notes review of each recruited patient after 12 months. Throughout the study, the patient will remain the clinical responsibility of the GP. Recruitment would involve a database search and mail out. We'd ask you to complete a search using a ready-made search you can import into either EMIS or System 1. Following the search, we would ask a GP at the practice to review the list of patients to consider whether it would be suitable to send them an invitation letter. You won't need to screen the whole list, but rather a selection at random, for example 50 patients, who we can then approach with an invitation letter. Eligible patients will be sent a mail-out pack containing an invitation letter, a participant information sheet and a free post-return envelope. We would also ask you to recruit patients opportunistically during consultations using a similar recruitment pack. Interested patients then contact the reduced team directly using the reply slip and the free post envelope. We therefore only have contact with people who have contacted us first. We'll ask you to complete a screening log of the patients you screened as eligible or ineligible for sending an invitation letter. Patients will reply directly to the study team using their free post envelope, and the study team will call patients to screen for eligibility. Eligible patients are then seen in person by the researcher, ideally at the surgery, where they will be consented to take part, asked to complete baseline assessments, and asked to make a GP appointment. The patients will then see the GP within 2 weeks of the baseline assessment, that is time point 0 there on the timeline. Patients in the intervention arm will then have their first telephone support call around 2 weeks after this GP appointment. The following 2 phone calls will take place at a time that suits the patient, ideally within 12 weeks of the baseline assessment. Patients in both arms will be followed up online or by post at 3 months, face-to-face at 6 months, online or by post at 9 months, online or by post at 9 months, and then face-to-face at 12 months. 15 to 20 patients in each arm will then be invited for an interview at varying stages throughout the trial so that we can capture viewpoints at different stages. In the intervention arm, patients will have access to an online resource called Advisor and have 3 telephone support calls with a psychological wellbeing practitioner. Practitioners at intervention practices will have access to an online resource called Advisor for Health Professionals. Intervention arm practices will be asked to read the guidance in the online tool for health professionals called Advisor for Health Professionals. We'll also ask you to arrange follow-up appointments for patients who are tapering and to remind patients to look at the patient digital intervention called Advisor for extra support and information. The patient intervention is designed to support patients who are tapering or considering tapering their antidepressant. The information is designed to support patients before, during, and after tapering. The information covers common worries about stopping, information about antidepressants, guidance on relapse prevention, help in understanding values and goal setting, and techniques for managing difficult emotions, for example, mindfulness and breathing exercises. Practitioners can see a summary of the patient content in the practitioner online resource. You can use this to help signpost patients to information that may be useful to them. Patients will receive 3 phone calls from a psychological wellbeing practitioner. The first call is 30 minutes and the second and third calls are 15 minutes. During the call, the patient goes through the PHQ-9 with the PWP to monitor how they're doing while they're reducing their medication. The PWP discusses any changes in mood, withdrawal symptoms, and any other concerns about tapering with the patient. Patients will be advised to speak with their GP if they're concerned about symptoms of withdrawal or relapse. The goal of the telephone support is to provide reassurance, motivation, and encouragement for patients who are tapering, and to encourage them to use the online intervention. We'd ask all participating practitioners to look at our online intervention called Advisor for Health Professionals, or Advisor HP. We'll send registration information directly to the GP or nurse's email address so that they can create their own login. Advisor HP contains information and guidance based on the latest evidence. There's drug-specific guidance on dosage tapering regimes, including switching antidepressants and using liquid formulations when indicated. It may be helpful to look at this before seeing a patient. The information in Advisor HP covers specific tapering regimes, guidance on following up patients who are tapering, guidance on how to distinguish between signs of relapse and symptoms of withdrawal, which can often be conflated. There's also information about patient experiences and expectations and some printable pages, including a printable tapering regime which should be handed to patients who are planning on tapering, and a printable summary of patient information that you can use to direct patients to information in the patient intervention. The reduced team will screen patients by phone using the PHQ-9, GAD-7 and exclusion criteria. We'll inform you of all recruited participants and of any ineligible patients. If a patient reports suicidal thoughts during screening or any assessment, we'll inform you so you can follow up with this patient. The study team will consent patients into the study at their baseline appointment and will arrange telephone support calls. If patients or practitioners have any issues with the online tools, we can provide support for that. The reduced team will conduct all questionnaire assessments at 3, 6, 9 and 12 months. Practitioners in the intervention arm will provide patients with a tapering regime, follow up patients to monitor their progress, and adjust doses as necessary. Practitioners will distinguish between relapse and withdrawal and treat accordingly. There's information in Advise HP on how to do this. Patients who relapse may need to be restarted on their antidepressants or referred for psychological therapy. We would ask that you inform us of any adverse events, and for serious adverse events, we'd expect to be notified within 24 hours. The psychological wellbeing practitioners will arrange their own follow-up phone calls with the patients after their initial phone call. They'll provide support for patients and encourage them to use the online intervention advisor. They'll contact the GP practice if there's a risk to the patient, but the patient remains the clinical responsibility of the GP at all times. In control arm practices, eligible patients will be invited to make an appointment with their GP to discuss coming off their antidepressant, and then it would be usual care for managing discontinuation. The study team will screen patients, inform you of all recruited participants and ineligible patients, flagging any patients where suicidal thoughts have been identified. We'll consent patients at baseline and follow them up at 3, 6, 9 and 12 months. Taking part in the study may benefit patients as they can have a review of their antidepressant medication, which may lead to a supervised tapering of their antidepressant. They'll be supported by telephone and internet support in the intervention arm. Taking part may reduce the risk of side effects, which increase with long-term use. Or patients may benefit from discussing with their GP and being reassured that they should not try to come off their antidepressant medication. It's possible that around 50% of patients who come off their medication may experience some mild withdrawal symptoms. Mild withdrawal symptoms are symptoms which can be tolerated by the patient and only last up to about 2 weeks. These don't need to be reported as adverse events. Moderate to severe withdrawal symptoms should be reported when withdrawal is severe or prolonged. This is likely to only happen to a minority of patients. These should be reported as related and expected adverse events. A relapse of depression or anxiety may occur in around 10 to 20% of patients over the course of the 12 months of the study and may require restarting antidepressant treatment. These should be reported as related and expected adverse events. Service support costs are £168.30 per practice, and these cover the database search and checking the list of patients. Excess treatment costs are £183 per patient, and these cover the time for the practitioner to familiarise themselves with Advisor HP and to cover additional consultations over the 12 months. Research costs cover postage for the mail-out and notes reviews. Practices should invoice us for these. The notes review is costed at the hourly rate of a nurse practitioner. In order to set your practice up for the trial, we'll need you to sign a practice agreement, complete a delegation log and provide us with copies of the CV and GCP certificate for the PI at this site. We'll provide you with recruitment packs and a site file containing all of the relevant documents for the study. Any health professional taking part in the study and seeing patients will be asked to sign a consent form. Please don't start recruiting until we've contacted you to say that you are now open to recruitment. Your site file will contain key reference documents, approval documentation, the recruitment procedure, important study documents and forms. From our feasibility study, we've learnt that adding the study information to your computer desktop or homepage can be useful. It can also be useful in the intervention arm to save a link to Advisor HP as a favourite in your internet browser. Adding as much detail as you can to patient notes for their study appointments will help when it comes to completing the notes review. If you like, you can include your own letter to patients in the mail-out pack. Some practices find this a more personal approach. The qualitative interviews with practitioners will explore views on implementation, following up patients, experiences of reducing antidepressants with patients, and experiences of using Advisor HP. We'll contact the practice during the trial to ask if any practitioners are interested in taking part. If you have any questions, you can contact the Reduce team at reduce@sotton.ac.uk, or you can contact us by phone.